and welcome back to the Journal of Oncology podcast from ASCO. This is Dr. Bob Miller from Johns Hopkins, consultant editor for the journal. We're hearing a lot these days about health information technology facilitated rapid learning healthcare systems. A key component of this vision is the bi-directional exchange of information between patients and providers. For oncology, one example is the systematic collection and use of patient-reported outcomes, or PROs, using validated instruments. This was the topic of a paper which was published online for the Journal of Oncology Practice in early August, entitled Qualitative Analysis of Practicing Oncologists' Attitudes and Experiences Regarding Collection of Patient-Reported Outcomes by Jagsi et al. I'm very pleased to have Dr. Reshma Jagsi as my guest this evening. She was the first author. She is Associate Professor and Associate Chair for Faculty Affairs in the Department of Radiation Oncology at the University of Michigan. Dr. Jagsi holds doctorates both in medicine and in social science, and she is an experienced health services researcher who is funded by the National Institutes of Health, the American Cancer Society, and others to study breast cancer patients' experiences and treatment decisions. Dr. Jagsi, welcome.
Thank you. I'm delighted to join you, and I just want to actually acknowledge my co-first authors, Anne Chang, Blaise Polite, and Bruno Medeiros. All four of us were together in the ASCO Leadership Development Program, and this was our leadership development project.
Excellent. Well, let's start with some basic definitions. What are patient-reported outcomes? Maybe give us an example of an instrument that is used to collect PROs. And I guess most importantly, why are these considered to be more accurate than clinician-collected data using standard history taking, say?
So that's a great question. So patients themselves can provide information that helps to inform shared decision-making and timely clinical interventions, as we all know. And this includes information on physical symptoms, functional status, emotional well-being, and health-related quality of life. So this is really similar to doing a full clinical review of systems with a patient to elicit their symptoms and experience and determine if there's anything that you've missed. The innovation is that now some oncology clinics are asking patients to report the clinical review of systems systematically using patient-reported outcome scales, like 0 to 10 rating scales or a specific survey instrument, at each clinic visit and or between visits. And these can be used to track concerns over time. The number of ways of doing this, and there's growing interest in using technology to allow patients to report symptoms, experiences, and satisfaction electronically to augment the traditional patient-physician interview. So that's what we mean when we talk about PROs. Given the promise of this approach, there's been growing work to develop tools for the systematic collection of PROs in both the research and the clinical settings. So you asked about an example. Actually, a number of validated instruments exist, but the ESAS, the Edmonton Symptom Assessment System, was the example instrument we showed providers in our study. And then finally, you asked about why this is better than standard history taking. So I think standard history taking in the context of a busy clinical encounter may provide a relatively limited opportunity for patients to express the full range and extent of their PROs can be elicited prior to a clinic visit and actually be given to providers in formats that can be used to efficiently affect the care individual patients receive. And this information can also be used to evaluate the quality of care or in research.
I was surprised that you said in the paper that your study was the first report of attitudes and experiences of PROs in community oncology practices. What kind of questions were you looking to answer?
So given the limited existing information that we had regarding practicing oncologist views, we decided to embark on a qualitative study, which was deliberately exploratory in design. So we were led by our participants in what the right questions were to ask. The main general issues that we were interested in exploring were general knowledge and experience with PROs, attitudes towards their content and format, how our interviewees felt that the widespread collection of PROs would affect their own practices, and their their perceptions of how patients and other stakeholders would react to PRO collection. But again, we let our interviewees guide us. We used a semi-structured interview guide and adapted it based on each interviewee's responses, sort of like doing a history with a good history with a patient, where the patient actually leads you to what's most important to the patient. So the subjects really led us to what the important issues were.
So talk about the interview protocol guide that your team developed. Can you describe what this instrument was and maybe give us some examples of what some of the questions were?
Sure. So we started off by asking if the interviewee had actually ever heard of PROs, and then if they had, we asked them about what the term meant to them and any of their own experiences with PRO collection. Then after that, we provided a definition sort of similar to what I just said earlier for what we were thinking of when we used the term PROs. And then we asked them to talk about what kinds of content they thought was appropriate for PROs to contain, how they'd like the information presented, and that's where we used this output from the ESAS, the Edmonton system, to guide our discussion. We asked them about the logistical issues that they thought that they might encounter if widespread PRO collection were implemented. Mm-hmm. And we asked them about their perceptions of how patients and other stakeholders would react, in their opinion.
Maybe talk a little bit about the sample population that you studied, what the interview process was, and who were you interviewing exactly?
Sure. So we selected medical oncologists who were part of practices that participated in ASCO's COPI program, so that's the Quality Oncology Practice Initiative, or in practices that were minority-based CCOPs, Community Clinical Oncology programs. And this was deliberately done to ensure representation of a diverse population of practicing oncologists with diversity in their patient populations and practice types as well. And we invited them to participate in a 45-minute interview with one of the 4 oncologist investigators who were leading this project.
And you said it was medical oncologists specifically, so not other types of oncologists?
We focused our interviews on medical oncologists, and 3 of the 4 of us who were interviewing were also medical oncologists. I myself am a radiation oncologist. And
how many interviews did you do?
We did 17 interviews and analyzed their verbatim transcripts. That may actually sound like a small number to those more familiar with quantitative social scientific research, but actually is a very robust number for the type of thick data that one obtains from interview studies and for qualitative analysis. So this was really meant to provide the richness and the texture and the depth and the nuance that one can only receive through an interview type study. And I encourage listeners to take a look at the article online, because I think that our respondents, really say things best in their own words. So it's I think it really yields some great insights. How
were the transcripts coded? What was the thematic coding process that you used?
So the 4 of us, the 4 oncologist investigators that were leading this project, jointly coded all of the interviews after training in standard methods of qualitative data analysis. Some of the codes were anticipated, but others were generated de novo from the transcripts, and this is actually a quite common approach in qualitative data analysis. We held multiple coding conference calls during which we developed an evolving coding superstructure based on the consensus of all 4 coders that we ultimately used to classify the responses.
So did all of the investigators listen to or at least study the transcripts of all 17 interviews?
So we divided up the transcripts. We did have, all of us had all 17, and we all looked at all 17. We divided it so that at least 2 of us formally fully coded each transcript, and then we read the other transcripts and the codes done by the others of us so that we could sort of see that we were all on the same page generally.
Tell me about your findings. What were the principal findings of this analysis?
So we found that participants varied quite considerably in their understanding and prior experience with patient-reported outcomes collection. Of the 17 oncologists whom we interviewed, only 4 actually had a really clear understanding and could sort of clearly define what PROs were and maybe actually even had experience using them. There were another 4 who had a relatively limited basic understanding of the concept, but couldn't get much past the sort of very basic definition of what they might be. And then there were 9 who were actually unable to describe what patient-reported outcomes were, or thought they could describe what patient-reported outcomes were, but did so inaccurately. So after we explained the nature and purpose of PROs to all of our respondents, just to get everyone on the same page, we found general enthusiasm for the potential for PRO collection to improve both the efficiency and the thoroughness of the patient encounter. There were several concerns that did emerge, and these included things like the possibility of information overload, the possibility of identifying problems without access to interventions, particularly in areas where referral resources were limited. Depersonalization of the physician-patient encounter was a really important concern that was raised.
Sure.
Impact on cost, potential impact on workflow. So even though there was enthusiasm that this could be an efficiency increasing intervention, there were also concerns that done the wrong way, this could actually have an adverse impact on clinic flow. And respondents really noted the key need for buy-in from other stakeholders in the practice, including office managers and nurses and clerical staff, all of whom will have to be involved if implementation is to go the way it should.
That sounds like a really important point, that it's not just a physician-only initiative. I guess if you're going to do this in a practice, you have to involve the staff that are going to be part of this.
Absolutely.
So talk a little bit about there was a sample instrument, the ESAS, the Edmonton instrument, and how did the interviewees react to that? I guess you showed them that instrument, and then you talked about tailoring it. So maybe go through that a little bit.
Sure, and there's a figure in the published paper that actually shows what we showed our interviewees. It was a sample report from the Edmonton system, and the participants were generally quite enthusiastic and provided positive comments about it overall. And these comments included comments about its relative simplicity in a positive sense, ease of use to prioritize symptoms, and respondents really endorsed the ability to track symptoms and the effective interventions over time using a report like this. Some felt that common chemotherapy-induced symptoms such as neuropathy and constipation should be included, so they felt that the list of symptoms was a little bit too limited at the current time. It wasn't developed to look at chemotherapy-induced symptoms, but they were thinking that if it were administered to a patient who was actively undergoing treatment, that you might want a slightly different battery. Others felt quite strongly that this would be an ideal way to screen for social and financial issues. We're certainly hearing much more about that these days, or to address functional status, in addition to the domains that are already covered in the existing instrument. Overall, in general, respondents felt that it would be best to pilot patient-reported outcome collection using an instrument with a limited number of general symptoms like the ESAS, but there definitely was interest in the idea of tailoring questions for specific patient populations in different phases of care. So as I mentioned, those who are actively receiving treatment versus those in survivorship or palliative care settings.
Do you think it's realistic to tailor a standard instrument like this? I mean, do you have to validate the tailored aspects of the instrument before you use it?
Yeah, I mean, I think with advanced technology, it's actually becoming quite possible to ask questions that then stem into different follow-up questions depending on the responses to the initial questions. So this opens up a whole new world of possibilities compared to eliciting patient-reported outcomes on paper. But absolutely, all of these instruments really do need to be validated.
So your findings were your interviewees felt that the patient enthusiasm for PRO collection would be pretty high, not surprisingly. And I guess this was also seen in a 2010 Livestrong report on electronic health information. You cite that as one of your references. But this really isn't happening that much right now. The routine collection of PROs, particularly in community practices, is pretty low. Can you maybe speculate on what you think the reasons are right now?
Yeah, I mean, I think some of it may be the lack of familiarity that we observed in this study. I mean, it was pretty striking to us that 9 of our 17 respondents really didn't know what patient-reported outcomes instruments were, or hadn't had any experience with them. And so I think some of it is that we need to have more information, because certainly once people were informed, there was widespread enthusiasm amongst our interviewees. I also think that at the moment, most practices lack a simple automated system through which PROs and other clinical information can be transmitted seamlessly and utilized without having an impact on workflow. So I think that with the advances in infrastructure that are necessary for a rapid learning system in oncology that are being led by ASCO, this is hopefully going to change.
So talk about the future. What type of future research questions do you think should be addressed in this area?
So we felt that our findings really suggest that the time is ripe for a pilot study of PRO collection, because we really think that it's only by gathering data from actual experience that we're going to be able to learn and rationally design the system to optimize its potential impact for improving the quality of care. So I think implementation research is the next step.
I'm going to read one quote from the paper just to get your reaction. The quote is, "To ensure physician buy-in, care is necessary to ensure that PRO collection is not perceived as a mechanism for the constraint of professional autonomy, but rather as an essential component of quality improvement. Moreover, oncologists must realize that future quality metrics will incorporate more patient-centered quality measures and that PROs will likely be critical to those measures." So that's the end of the quote. My question is, what do you think will need to happen either from a policy standpoint or a practice standpoint to sort of jumpstart this type of transformation?
I think that's a great question, and I think that was a very important quote from our paper, and it certainly came from the interviewees themselves. I think that ultimately it's engagement of practicing oncologists in the design of the rapid learning system of oncology care that is so critical to jumpstart this and to ensure that the changes that it brings are appropriately viewed as coming from within our profession and designed to improve quality rather than being imposed by some external body upon us.
Any final comments or perspectives that you want to share?
I guess I'd like to close on the positive note. I think that perhaps the most important finding was the general enthusiasm that we observed for PRO collection. It was really heartening. Although there's obviously much work to be done to ensure that patient-reported outcome collection succeeds within the context of a developing rapid learning system of oncology care, the promise of this approach is really exciting. And I think that as long as it is carefully designed and implemented with input from practicing oncologists, from patients, from other key stakeholders in the practices, and the public, that the oncology community really has a great potential to benefit from this innovative approach.
Dr. Jagsi, thank you so much for sharing your perspectives on this paper and this very important topic.
Thank you so much. This was great.
And thanks again for downloading our podcasts and for your readership of the journal. If you find this podcast format helpful, please consider giving us some feedback by either commenting on our page in the iTunes Store or sending an email to jopeditorsdesk@asco.org. This is Dr. Bob Miller for the Journal of Oncology Practice. Thank you very much for listening.